Good afternoon, everybody. Okay, I'll try to speed up our time here a little because there's not as much data. Here's my disclosures. I just think it's kind of important to mention that we've been treating prostate tissue for ablation with lasers for a long time. Of course, I'm going to present outcomes and treatments for malignant tissue, but don't forget about benign. What's interesting to me about this is the power that's used for benign tissue, right? Look at 120 watt holmium laser. Now there's 150 watt coming out. For green light is 180 watt. But look what we use for malignant tissue, all the way down to about 14 watts with Visualase, which we'll talk about in a minute. So we're using way, way less power for malignant tissue. I just find that interesting. Most laser catheters in use for malignant tissue right now are going to be liquid cooled, so in a sheath that runs fluid around it to cool the laser, and they're going to be using a diffusion tip to focus that laser energy into a discernible region. The one different laser is the CLS laser, which is a non-cooled laser. It's a single fiber. The Somatex there in the beginning there, that was the first kind of malignant tissue ablation laser that was developed. This is discontinued now. That was a very high power laser, relatively speaking, up to 30 watts even, for longer treatments, and it was originally designed for liver. But that then shifted to the Visualase, which is the mainstay of FLA treatment now in prostate. CLS I mentioned, and Urolase is something I'll talk about at the end. That's used specifically for nanoparticle activation ablation. I just wanted to be comprehensive, and so I will briefly mention photodynamic therapy because it also involves lasers, although it's not directly treatment from the laser. But what this is a photosensitizer, which is infused most often intravenously and accumulates in the target area, and then it's activated by a near-infrared laser, which is applied via a standard transperineal brachygrid setup. So these are the listed in that table were the 7 or 8 different agents that have been tested and reported over time. The most common one, most familiar, is probably this one, which is known as 2CAD. And this generates superoxide and hydroxy radicals when illuminated with the near-infrared laser, which then creates a cascade leading to coagulative necrosis in the cells. There was a couple papers that came out about 5 years ago for 2CAD. This is one of those, and you can see that the design was somewhat flawed, but what we were doing back then, I guess, was looking at very low-risk disease, and so randomized patients with very low-risk disease to active surveillance versus this 2CAD therapy. So maybe something we wouldn't randomize today if we were to design a new trial, but what it did show over 4 years was a significant reduction, about half of the time men needed to go on to radical treatment. That's the outcome you're seeing here. And so the orange line is about 50% of the patients on active surveillance over 4 years went on to radical treatments compared to only about 24% of the men getting 2CAD. So that seemed promising. The problem was that the side effects were too great, especially erectile dysfunction, and the FDA did not give this their stamp of approval, and so we're not seeing this in use much. So let's move on to the mainstay of laser interstitial thermal therapy that we really want to talk about here, or lit therapy, or FLA. This is similarly applied most commonly with the Visualase laser through a brachytemplate grid, as you see there, using a cooling catheter system that the laser goes inside of. And there's a monitor, there's a water pump when you do this. You need a cooling water pump, and then you need a laser source generator. The unique aspect of FLA is that it's most often applied within the MRI scanner, and so in real-time monitoring, you can monitor thermometry to look for the heat. So this is just an example from one of the better-known papers published on this, where you can see in that big blue square graphic, that red dot up near the top represents the ablative thermal temperatures generated from the laser, and that sort of cooler area around it is the temperatures dropping off. And so then if they were to draw a suggested area of ablation around that in the orange, it would look like that on the next slide, and you can sort of faintly see this blue dotted line which outlines the prostate. So that's sort of the ablation within the prostate they expect. That mostly correlates with the follow-up imaging you see in that C graphic. And then on home mount, when they removed these prostates, they were able to look at that, and it does correlate very well with the coagulative necrosis that is seen. The problem is that those blue areas in ink drawn around that whole mount specimen also represent active cancer that wasn't treated. And so that's one of the pitfalls of FLA, is that it can't treat a large area per se. This is one of the bigger reports that has been published a couple years ago from the UTMB Galveston group with Walzer and Steve Williams. This is showing their setup. They did 120 patients using transrectal in-bore FLA, treating for a couple of minutes at about 17 to 18 watts of power. You can see that at target temperature of 60 degrees. This, it's also always important for us to look at what is the outcome that's being measured in these studies that we're assessing. So this outcome is, freedom from radical treatment, let's say. And so that would be done if a subsequent MR or biopsy were to show cancer still there. These patients then might have gone on to radical prostatectomy or what have you. And using that metric is a little flawed, as we know. These patients at 6 to 12 months underwent an MRI. Only if there was some suspicion would they get a biopsy. So in that case, about 18% of patients at 1 year had positive cancer within the field, and at about 83% were free from treatment, further treatment at 1 year. That dropped to about 73% at 2 years that you can see there. So let's just assume that they were actually catching all of the recurrences, about 73% in-field success at 2 years. We do know that MR invisible is going to have about a 30%, about a third of the time it's going to still be positive. So it's important to look at the metric, but there you go. Let's just take that at face value for now. Another group that has reported some data, and I mentioned there's not a lot of data, but this is another big group in the country that's doing FLA. That men can go to their website and sign up and get this. They have a clinical trial going on. That's good. They haven't published this yet, but they have reported some of their data. And so of the 158 men that were treated up to this point, which was in 2020, and 122 had undergone 6-month biopsy. That's good. All of their patients are getting 6-month biopsies. And so using that more specific metric, we can see about 41% of those patients still had cancer in the treatment zone. If we look at a more Delphi or significant definition, 26%. And so let's just take that at face value, around 75%. The other Walzer study showed about 73% using an imperfect definition, I would say. Okay, the beauty, perhaps, is the quality of life, and so no changes in IPSS or SHIM, which is true for the other study as well. Well, let's take it out of the magnet. So a couple of companies have developed FLA systems now that you don't need to be doing it in the MRI scanner. Probably the most well-known is the CLS system that you see on the left there. They've actually reported some of their outcomes. Their first 25 patients were reported at an annual meeting, but have not been published in the literature yet. And they have about a 73% 2-year in-field success rate. So very similar to what we were seeing with the in-bore results. And then the group out of UCLA with Advinda Health has developed their own system you see on the right called Focal Point. There's a YouTube video about their technique you can watch, but they haven't reported their outcomes yet. And then lastly, I'll tell you about one more laser application that we developed using gold nanoparticle technology, similar to photodynamic, where you infuse the particles systemically the day before. They accumulate preferentially to saturate cancer, but not benign tissue, and then we activate that with a near-infrared laser. So it's different than FLA because we use a laser dose that is subablative. So I mentioned that for FLA, we're using about a 14-watt power. For this, we're at about a 5 to 6 watt power. That alone will not destroy any tissue. It will only activate nanoparticles, which will then destroy the cancer cells that they reside in. So it's a very cool, promising idea. This is another graphic representing how at that near-infrared wavelength, it will only activate the orange peak there, where the nanoparticles. It will not activate or excite blood or water, for example. It's a cooled catheter system. Here's an example. You can see a tumor at the left anterior prostate on the MRI images. The setup is similar to other laser therapies with a brachy grid. Trocars are placed to surround the tumor to get an 8 to 10 millimeter margin, and then the laser would be sequentially activated through each of these trocars using image guidance. Here's a post-op example. You can see that ablation zone on the right side there, which respects the capsule, and there's no effect to surrounding musculature or surrounding tissues. Here's another example. You can see on the left-hand side, only in the area of nanoparticles does the tissue get hot to ablative temperatures, and that below that little red spot on that graphic is an area where the laser would be fired in the prostate, but no heat is generated. So it really does work that way. The picture on the right shows the urethra, and then over here you can see a small little circle, black circle. That was one of the trocar sites, and there's a 48-hour MRI. And it's just showing you that this area is just 2 millimeters from the urethra. And when you look at the ablation phase here, you can see the urethra is intact even though that laser was fired right next to it. And it's only following where the nanoparticles went, which is where the cancer was. So pretty cool stuff. How did it work? We did 2 clinical trials. We only treated patients with Gleason 7 or less disease, and we used the Focal Therapy Society Delphi criteria of no Gleason 7 or less than 3 millimeters of Gleason 6 at 1-year biopsy. All patients got 1-year biopsies. Here was our feasibility trial with the first 44 men, and I'm not going to go into all the details, but I'll just tell you our outcomes were about 73% in-field biopsy negative at 1 year, and no change, significant change for median metrics in the quality of life scores as we would want and expect. Here's an aggregate of both trials. 100 men were treated, and similar 1-year success rate, currently at 71%, slightly evolving. This will be published eventually. And again, quality of life remained the same. I will say anecdotally, you see that we had a number of different sites. Almost none of these sites had experience in this, and so we did notice heterogeneity. You know, it's important, because it's so ultrafocal, it's important to get the technique right. You have to have good registration, good imaging, good placement of trocars. And when sites could adapt and get that right after a learning curve, their success rates were up to 90%. But aggregate of 70% is very acceptable from what we've already heard today. So I think this is a really exciting, interesting technology that we should see more of. It's currently in the FDA's hands for consideration. Thank you very much.